Please have a seat first. We'd like to invite now our last speaker, Dr. Shozo Ishihara, to share with us a case of intra-aortic balloon pump during primary PCI with high thrombus burden and cardiogenic shock. Dr. Shozo, please.
Thank you, Chairman. So I'd like to talk about the IABP during primary PCI with high thrombus burden and cardiogenic shock. But so at first, of course, the IABP is a very important device. But not only IABP, but we have some other mechanical cardiac support devices. So okay, it's okay. So, this is the DSC guideline of SCS management to 2023, and so now we can see the recommendation of the mechanical support. So, in some situation, we can of course use a mechanical MCS device, and it is somehow supportive, so that consider class 2B. But so routine use of IABP in SGS with shock cardiogenic shock patient is somehow harmful. So it means a class 3. So that the patient selection is very, very important. So this is also the SKY consensus statement of the classification of cardiogenic shock. So we consider the IABP introduction from the class B to class 3, and class D and class B, we need more strong cardiac support, including impeller or ECMO or something. So, so this is the evidence of mechanical MCS for cardiogenic shock. So IABP is okay for class B, class C, and somehow class D. But so more stronger support, we have to use impeller and also ECMO. But as you know, problem is the price. So the cost, ECMO is 3 times expensive than IABP, and impeller, I don't have to say too much expensive. But so the problem is still IABP have the no benefit of mortality of routine use. So that's so as repeatedly I say, so selection of the patient is very, very important. So this is so the situation of the mechanical support. So which kind of patient we need? So of course, one of the so important situations are cardiogenic shock, and also sometimes we do the left main bifurcation lesion, and also the multi-vessel disease, and also high thrombus burden. So this is the topics I have to talk today, and also another one is a severe LV dysfunction. Low ejection fraction, so that in selected patient, not routine use, so we can use IABP. And so today I will talk about these two topics. So at first, maybe you know IABP, but so IABP is like this. So I'm sorry. So approach site is femoral, and in some situation we can insert from left brachial artery. It is also the one option we have to consider. And also the appropriate position and the size. We have to choose the patient. Maybe European patient is very big, but Asian patient, so for example, Vietnamese, and also some Asian patient is not so high. So that we have to understand the appropriate position. So a little bit lower of the left subclavian artery and also upper of the renal artery, it's very important. And this is also the very fundamental understanding of the IABP. So we have to understand the dichrotic notch, and also we have to inflate the IABP balloon during the diagnostic timing, so that in this point, nowadays, IABP machine is automatically, so that we don't have to consider about that. So timing of the IABP, inflation, depth, we don't have to just automatically movement. But we have to understand the appropriate movement of the IABP is very important. So how to check it is working well or not? This is very important. We have to understand the pressure curve, and at first it is better to set the assist ratio 2:1, and so we can understand the left wave is so original. So after the IABP, and so next one is original systolic pressure, and then after the balloon augmentation, it means a balloon inflation. At that time, of course, the pressure is increased with the balloon assist. But the important point is after the deflation of the balloon, so the original diastolic pressure should be decreased. It is an important point of the IABP support. So the to decrease the diastolic pressure, the IABP is working. And so after that, following that, so decreased systolic pressure after IABP is also important. This is number 2 and number 3, so decreasing pressure of original one. So it's very, very important point. So we have to assess, is it working or not? If IABP is not working like this, we can consider different support, or we can finish using IABP. And so it means a systolic unloading and also afterload reduction. It's very, very important. So indication of IABP is shown, but so of course that depends on the patient situation. Of course, low blood pressure, high wedge pressure, and cardiac index is very low, and also of course the patient situation, so cold tense, cyanosis, urine volume lower, and something. So now I will show one case of the AMI, anterior MI, and so relatively young patient with coming with VF. So he failed after chest pain, and so paramedics found VF and AED was so effectively used. And after that ROSC, and he was carried out to our hospital, and we see the very elevations of a chest lead, and so we see the total occlusion of proximal LAD. And so in this point, systolic blood pressure is 90. So which is better to IABP first, or mechanical support first, or PCI first? In this patient, I did PCI first because fortunately patient is relatively stable, so that thrombus aspiration first, and balloon inflation and stent implantation very quickly, maybe 10 minutes or 15 minutes, something. So after the procedure, after recanalization, patient is still okay, but tachycardia and also the systolic blood pressure is 70. So that we can retrieve the guiding catheter and also change it to the IABP. It's a very easy way. And so in this patient, fortunately, so very broad anterior MI, but so PCI first strategy and then IABP insertion is acceptable. And next is so high thrombus burden patient. Of course, we sometimes face the very high, so huge thrombus patients. At that time, it is difficult to get leaf perfusion, and also we sometimes face slow flow phenomenon and also no leaf flow, so that we have to do some balloon dilation, but the long inflation is better. So in Japan, we have the perfusion balloon. We can do the long inflation, but so it is some limited. And also in some situation, direct stenting is better than balloon inflation. And aspiration is also so effective in some situations, not routinely used, but sometimes high thrombus burden we have to consider. And so Dr. Lamho mentioned ELCA. ELCA is not so work for the calcified lesion, but so thrombus for high thrombus burden. So ELCA is sometimes effective, and also we can consider distal protection, but this is also not routine use is recommended. So distal protection is only useful for the large plaque burden, high possibility of distal embolism, and also MI in saphenous vein graft is strongly recommended to use distal protection device. Sorry, yeah, it's okay. So yeah, not moving. So sorry. So that this is a right coronary STEMI patient. So we do the radial approach and so sequence guiding catheter, and also the So there are so many, we can see that a lot of thrombus, so that, okay, please wait, maybe, I'm sorry, but it doesn't work. So that after the balloon dilation, yes, so we see the still huge thrombus there in this situation. So we put the stent, the relatively long stent, and then after the deployment of the stent, so still the distal flow is not so good, and still ST elevation existing. So that thrombus aspiration again, and also using aspiration catheter for the delivery of the so nitroprosid or so vasodilator, so super selective injection like this. So finally, so coronary flow get better, and after getting the flow recovery, post dilation, and the final result is acceptable. For this patient, fortunately, I don't have to insert the IABP. So using the aspiration catheter and also giving the vasodilator. But so this is another patient of the 56 years old male ACS. And after coming to our hospital, blood pressure is already 70, so very low. And heart rate is 38. So shock and bradycardia. And we see the right coronary. So unfortunately, they are totally occluded at proximal part. And then open up with, so after the aspiration of the thrombus, because there may be a lot of thrombus, so that aspiration and also balloon dilation. But unfortunately, still, flow is not good after aspiration and also the balloon like this. So in this point, we check the IVAS and put the stent soon. But unfortunately, after the stenting, the flow is not still good, and so still bradycardia consisting. So in this situation, in this situation, we inserted IABP and the temporary pacemaker, aspiration again and again, then giving that vasodilator. But unfortunately, we couldn't get the TIMI3 flow, TIMI1 or something, so that we gave up at this situation. Of course, patient have the heart failure, and so still pacing. But after 4 days, so ECG was recovered, and also RI scintigraphy showed still viable of the inferior wall. So that we did later phase of the PCI for this occluded RCA. Fortunately, so we can cross the wire and deliver the stent. And finally, we can recolorize this right coronary. So in this patient, it is difficult to get the complete revascularization at the ACS timing, but so that to get the time for such purpose, IABP is sometimes very important. So my strategy for my MCS: if blood pressure is stable, immediate primary PCI. And if the patient's condition is not stable, at that time we insert the MCS. And blood pressure is unstable at coming to the hospital. At that time, introduce IABP first, and then PCI is more safe. And VF storm or CP, of course, IABP no working, so that start VA ECMO is mandatory. So we should understand the IABP and any other MCS device, and also we should consider the cost and efficacy. So MCS is sometimes useful, but we should select the patient, and IABP is still useful in some situation, and especially high thrombus burden patient we should consider. And Impera and ECMO is of course effective but expensive, so that we should consider balance. Thank you for your attention.
Thank you, Dr. Sojo, for an excellent lecture for IBP and an old device, but still be used now in our cath labs.